Good afternoon, all. So the next talk, so we've had three talks on the basic principles and workup of a thoracic patient. So in the next half an hour, we will try to address a very challenging but difficult pathology, which we deal with a lot in the United Kingdom. So this will be focused on surgery for emphysema. So this is Leicester, the place I come from, which has a lot of history going back to the medieval era. And it is about 100 miles north of London. Most people know Leicester these days because we managed to lift the English Premier League Cup a few years ago. But more importantly, our chairman crashed and burned in a helicopter which took off. Lung volume reduction surgery is something like this, because if 1 minute you feel you've done the best thing, the next thing the patient can go down into tubes, and Amiral Sisi's already highlighted how challenging it is to pick these patients. So what we will try to do is to give you the options of management for patients with volume reduction in the next 25 minutes, 30 minutes. So LVRS is not new. This goes back to 1950s when Brantigan, a surgeon in America, decided to chop off the non-functioning lungs using basically Robert's clamps and tying them off. Obviously, not surprisingly, that the morbidity and mortality was quite high, so this never made it to the mainstream. Until Joel Cooper decided to popularize this in the late 1990s with the advent of LVRS and stapling technology. But the resistance came from the insurance companies. They said, we will not fund it because what's the evidence it works? So this brought about what is probably one of the landmark trials in thoracic surgery, which is the National Emphysema Treatment Trial, wherein patients were randomized into volume reduction surgery and medical therapy. And not surprisingly, it did show that there was a benefit. However, when they did the analysis initially, all comers, there was a significantly high mortality. So they made the headlines that LVRS kills patients. But when they did the subgroup analysis, they realized upper lobe preponderant disease with low exercise tolerance got a good outcome, and non-upper lobe disease with high exercise tolerance didn't have it. And the comorbidities were what killed patients, and careful selection actually gave them a good outcome. So this became a niche procedure, and the United States still hasn't recovered from that initial wave of nihilism where LVRS was seen as a procedure which may harm patients, whereas in the UK, it's grown over the years. So this is just a slide from the national audit, which was published a couple of years ago. As you can see, that's us in Glenfield Hospital, and we do pretty much way above our nearest colleagues. So we do about 150 over 3 years, and the nearest unit is the Brompton and Harefield, which have done about 90. So we do a lot of this because in our unit, this has been happening from the time when Joel Cooper introduced LVRS. So Leicester have been doing it from 1997 onwards. And the success to our program is because we work in a multidisciplinary team that includes respiratory physicians, professors in respiratory medicine, radiologists like Dr. Bajaj, the anesthetists, the MDT coordinator, and rehabilitation specialists. All of these people help us choose the patients well, and then we offer them surgery as a part of multimodality treatment, because we rehabilitate the patients, they have surgery, and then they are further rehabilitated. So this is our protocol in Leicester. So the referral comes through either through the respiratory team or the thoracic surgeons. All the radiology is reviewed by the team, and we discuss it all in the MDT. We insist they have stopped smoking, they have completed pulmonary rehabilitation, then they are offered volume reduction in one form or the other. If they're too good, we wait on them. If they are not suitable due to comorbidities, we turn them down. So the required investigations include full lung function tests, including plethysmography and ABGs. Why plethysmography instead of gas dilution? Because plethysmography allows us to volume map the trapped air, that is the residual volume, accurately as opposed to gas transfer dilutions. We do a CT scan. Of late, we incorporate CT reconfiguration using statics, which helps us define the volumetry, the density of the lung parenchyma, but more importantly, the fissures. I talked about the fissures in the anatomy talk earlier on. The fissures become paramount when we are thinking about a non-surgical management in these patients using endobronchial valves. We also get a quantitative perfusion scan to see what is the area which is perfused and functioning versus what is not. And finally, the heart is attached to the lungs. So we need to see that the heart's in good nick by echocardiogram, which always is challenging in these patients because of the hyperinflated lungs. So they may require an MRI as appropriate. So that's just a CT. You've seen a flurry of images earlier on. Upper lobe preponderant emphysema. On the right is the perfusion scan, which shows that area does not have any perfusion. So if I decide to remove this, it will offer the patient more volume for the normal lung to expand and make their quality of life better and oxygenation better. So this is the process map. Outpatients, VQ scan, PFT, high resolution CT and ABG. They're seen and they are then allocated from early 2015 onwards to an endobronchial valve or surgical volume reduction. So we've always been doing keyhole volume reduction in Leicester. That's now also offers endobronchial valves. So the selection criteria is, is a patient obstructed? If the FEV1 is between 20% and 40%, they meet criteria. Is there distension, that is residual volume of greater than 250% and a total lung capacity of greater than 120? Is there destruction affecting gas transfer? So we aim to have a DLC of at least more than 25%. And there is heterogeneous target as dictated by the HRCT and Q scan. The surgical strategies in the olden days used to be a sternotomy and bilateral volume reduction, thoracotomy and volume reduction. So that is how the lung is once you've resected it. But off late, it's VATS from progressing from 3-port VATS to these days a single port VATS. So you get a very good view. You get all the dissections off and you take the apices on the left and right for the upper lobe preponderant disease. We use the arch of aorta as a benchmark on the left side and the azygos on the right side. So on the left side, you see a single port VAT. So all the instruments go through that small port and you get a boomerang shaped lung, which is removed, allowing the rest of the lung to expand. And you can also use volume reduction in conjunction with nodule excision. So we're expanding the role to patients with lung cancer in those areas. So once you've taken it out, there's a lot of raw area. Just breathe. So we use both staplers. We've used the Covidian or now Medtronic staplers or the Echelon staplers, and you take it out as a boomerang of tissue using the dissectors. These lungs are quite damaged, so they always are preponderant to leak air after that. So we've used a variety of supplements to help with the lining of the staple line. So this is seam guard. We've used peristrips, which is bovine pericardium mounted on the staplers. So once you staple, there is a buttress. We've used bioglue, which the cardiac surgeons use in aortic surgery, but it is a very good adhesive. So once the staple line is done, the glue is allowed gently using the applicator, which has got a spreader tip. Off late, we use tissue patch, which is a thin film, which can be laid on to the staple line. So this covers both sides of the staple line and reduces air leak. So volume reduction took a pause because of the original reporting of the net. But the fact that surgeons were not offering volume reduction surgically meant companies explored other alternatives to achieve the same thing. And one of them was endobronchial valves. The other technology was endobronchial coils. Both of them have now made it to the mainstay of therapy. So the endobronchial coils, if we take it, is a small one-way valve which is placed in distal airway. So you will go to the sublobar bronchi and place them. And the study showed that, the Venn study showed that it does give patients benefit, but not as good as the net trial or the surgical LVRS. So they then went to look at subgroup analysis and realized if the patient had heterogeneity, if you could get a complete lobar exclusion, this is where the fissures become very important. We talked about the fissures. So if the fissures are intact, by blocking that upper lobe, one is achieving no air going in. The one-way valve allows the air to come out, the lower lobe expands and fills the space. On the contrary, if the fissures were incomplete, there is going to be collateral air coming from the lower lobe to the upper lobe, so they did not get good outcome. And we use a variety of technology to do this. Stratix is a device which calculates the fissure and the density of the tissue using a high resolution CT. So it will tell us whether this fissure is complete or whether it is incomplete. If it is complete, what is the percentage? So if you have a greater than 90% completion of fissure integrity, then the valves will work. So if the lines are black, like greater than 95, like I said, it'll work. The alternative is Chartis. In our unit, we use both. Chartis is an on-table assessment where you place a bronchoscope with a balloon and it has a sensor which reads the air expanded. So you see a waveform and you expect the waveform to flatten if there's no collateral ventilation. On the contrary, if there is collateral ventilation, that waveform will continue and valves may not work. So we are doing the upper lobe is occluded. As you see, gently that comes down. So we then know if we put a valve in the upper lobe, it will work. Yeah. On the contrary, if this continues and the waveform go up and down, then it is not a good outcome, and putting a valve will not achieve lobar collapse and thereby improve the patient's symptoms. So I'm just going to play a couple of quick videos just to run through what happens.
Pulmonx, breathing innovation into life. For patients with severe emphysema, Pulmonx offers the Zephyr endobronchial valve, a minimally invasive treatment option with over a decade of proven clinical experience. To identify which patients will respond to the Zephyr valve, the Pulmonx Chartis system provides precise pulmonary flow and pressure readings, allowing physicians to assess the patient's collateral ventilation. By identifying diseased lobes with no collateral airflow, physicians can optimize the valve placement for endoscopic lung volume reduction. Targeting the diseased lobes with no collateral airflow, the Zephyr endobronchial valve is the first choice in treatment for patients with severe emphysema. This simple implant procedure uses a standard bronchoscope and flexible delivery catheter to guide the Zephyr valve into the target lobe and desired airway. Once deployed, the self-expanding valve conforms to the bronchial wall and creates an airtight seal. The Zephyr's one-way valve prevents airflow into the diseased portion of the lung while allowing trapped air and fluid to escape. During treatment, several Zephyr valves may be placed in the diseased lobe. The valve can be easily removed, if necessary. By controlling airflow, the Zephyr valve reduces the volume of the diseased lobe, allowing the healthy lobes to expand and function more efficiently. Additionally, the diaphragm returns to its natural shape, improving breathing mechanics. The Pulmonx solution is the cornerstone therapy in
So these are a few patients where we've used endobronchial valves. As you can see, this is a treated left upper lobe. This is another patient, different patient with a treated right upper lobe, where you can see the upper lobe collapses. That's the middle lobe there, and the lower lobe just moved up. And that's the diaphragm, which is now risen. Normally, the diaphragm would be here, flattened out. And these are the indications and the do's and don'ts when it comes to case selection, because you want a patient who has emphysema with a complete fissure with no collateral flow, meeting the criteria which we said. On the contrary, if there's lots of fibrosis, incomplete fissure, bronchiectasis, pleural pathology with adhesions, and more importantly, there is a nodule there, then it's probably not an ideal patient to be valving. So we need to be careful which therapy we choose on the basis of the patient we operate. And let's not forget, we need to take into consideration what is the cardiac comorbidities of these patients, as these may have a bearing in the final outcome. But more importantly, in my anesthetist offering the patient a general anesthesia. So the other alternative is a therapy wherein you use small nitinol preformed coils. So in this technology, we do not cut away any tissue like keyhole volume reduction. We do not block away any lung. So we are relying on the fissure. Whereas what you do is to pull the lung in by these preformed coils, thereby improving the compliance. So this procedure is done with the radiology assistance. So it's done under a C-arm. The catheter is placed. Then a fine wire is advanced till the subpleural region. Then it is removed and the coil is straightened in an applicator and placed there. So when the applicator is removed, the coil, as it is made of nitinol, which has shape memory, will get back to the same shape, thereby pulling the lungs in.
There's a novel, minimally invasive treatment, the Renew Coil, designed for emphysema. Patented shape memory nitinol coils are programmed with a double loop. Straightened for insertion into the lung, they then return to their original coiled shape. This unique action gathers in loose, diseased tissue, which is expected to shorten treated airways and retension the lung. 10 to 12 coils are typically placed throughout an upper or lower lung to provide retensioning of the entire airway network. Maximal benefit is achieved with bilateral treatment. The coils are designed to improve lung function in 3 key ways. To have a retensioning effect on adjacent lung tissue, thus enabling more efficient contraction during the breathing cycle. To tether and hold open small airways, preventing airway collapse, which reduces air trapping and hyperinflation. And to compress diseased tissue, improving diaphragm mobility and providing room for healthier tissue to function. Only Numerex has developed a minimally invasive treatment designed to improve patient outcomes through mechanical reduction of air trapping and hyperinflation. There's a novel.
So this is how the patient looks after treatment. This technology is currently only available in the continent. We used to do it in the United Kingdom, but it is now withdrawn with the merger of the companies, and it is no longer done in the UK. But the continental surgeons still use the endobronchial coils. So what is the evidence for all these treatments? So this was a Cochrane review of the bronchoscopic volume reduction, which agreed these technologies, predominantly the endobronchial valves, offer significant and meaningful clinical short-term outcomes. It improves health outcomes, and it was at the expense of increased adverse events. The current evidence was not sufficient to assess the long-term outcome of the bronchial valves, but more importantly, it couldn't assess mortality because there was no mortality in this series. So they recommend a stringent long-term follow-up of these data to see the role of the endobronchial valves. On the contrary, volume reduction is accepted as an effective treatment for selected patients with severe emphysema. It will lead to better health status, and lung function outcomes, especially in patients with upper lobe preponderant disease with low exercise capacity. It is associated with early risks. However, in carefully chosen patients, and in Leicester, we've come up with a scoring system for volume reduction called the Glenfield BFG score, which takes into account body mass index, the FEV1, and transfer factor as 3 variables which help us determine the high risk from the low risk patients. So LVRS clearly shows to improve outcome, and the morbidity and mortality, which were shown in NET, is clearly lower in our present day practice. The UK average mortality is about 2 to 3% for LVRS patients done bronchoscopically. And with careful case selection, these can even be reduced. And we need randomized trials for EBV versus LVRS, was an editorial published in 2015. Fast forward a few years, we've just completed recruitment into the CELEB trial, which is a one-to-one direct comparison of unilateral VATS LVRS versus endobronchial valves. So there were 4 units which recruited: Leicester, Brompton in London, and Baths in London, and Glasgow, plus Sheffield, which had very few patients contributed. And the idea was eligible patients who had a Chartis assessment and had intact fissures were then randomized into keyhole volume reduction on one side and bronchoscopic endobronchial valve placement on the other side, with a stringent follow-up planned for acute outcomes as well as long-term outcomes, looking at quality of life, lung function, MRC score, and improvement in their CAT score and BMIs. What all of this technology allows us to offer personalized procedures for these patients. You could do a VATS LVRS, at a later date do an endobronchial valve, you could do a coil, but it should all be done in a lung volume reduction multidisciplinary team setting. So this is a patient of mine who was referred to me in 2011 with alpha-1 antitrypsin deficiency and preponderant left lower lobe emphysema. So in 2012, I did a VATS LVRS. And this was her 2 years down the line. As you all know, the lower lobe patients tend to do less well than the upper lobe preponderant patients. So she's back again with hyperexpanded lung and the diaphragm's flat. So the MDT decided to get a VQ scan, which showed that there were still targets with hypoperfusion in the left side. This is an X-ray the day before procedure, and this is the day after procedure, wherein we placed 3 endobronchial valves in the left lower lobe. So the hyperinflated lung then starts collapsing and settling down. And fast forward 3 years, she now comes back again with the same problem. On this occasion, because the disease process on the right side was more diffuse with no targets and no integral fissure, by now this patient is 79, we decided to valve the right side. So this single patient has had all 3 modalities of treatment, and this has stretched the benefit of the procedure over a period of 10 years. So VATS LVRS remains the main intervention in our practice for severe emphysema. Specialist MDT is an established practice in the UK, and it should be part of any practice offering volume reduction. Endobronchial valves are suitable alternatives, and endobronchial coils as well. And the introduction of endobronchial valves and coils and MDT have increased the number of patients benefiting from this. And the trial results, when they are analyzed and published, will guide us further in terms of how best we treat these patients. I'm going to finish off with this. This is a patient of mine.
Hello, my name's Don. I've got COPD. I started smoking when I was, mid-teens, I suppose, and carried on till I was smoking 20, 30 a day. I gave up 22 years ago. I've got emphysema. You probably know what that means. In my case, my lungs have expanded to more than twice their normal size. Somebody told me that what this means is that the air very easily gets into the bits that don't work. The parts of my lungs that did work, the elastic bits, were more resistant, and the air didn't get there, which meant that I couldn't get oxygen into my blood, and that meant I couldn't get oxygen into my muscles. And so I was constantly fighting for breath, constantly tired, always struggling. To go for a walk was more or less a punishment, and I hated it. The answer, I was told, was to reduce the volume of my lungs. which didn't make any sense to me at all. Here was me struggling for breath, and you want to take some of the size of my lungs away? But indeed, lung volume reduction surgery was in fact for me the way forward. Of course, the whole idea scared me to death. I had the vision of a surgeon ripping my chest open and pulling parts of me out of it. Now, nothing of the sort. Medical science nowadays is a lot more sophisticated. They do it laparoscopically, which in normal parlance is keyhole surgery. Tiny incision. They needed to get the instruments in. They have a little camera with a light, would you believe it? And they actually stapled part of my lung. No, not with the kind of stapler that you have in your office desk, a medical device. And by this means, your surgeon will tell you more than I can. By this means, they reduce the volume of my lungs. And that means that air gets to the good bits, the bits that work. Prior to that, believe me, I was an invalid. In fact, the weather we're having today was the worst possible conditions for me. Cold, damp, nothing could be more punishing than to be asked to come out and walk in this. But guess what? Now I can. It's improved my whole lung function. It's almost miraculous. 6 weeks ago at Glenfield, I got my life back. I've been walking every day since. My lungs are getting stronger. My muscles are getting stronger. I'm becoming more and more fit, and I'm enjoying it. I've even got my wife back. She's no longer my carer. She's my partner.
Thank you.